Hello, everyone, and welcome. Thank you so much for joining us today. My name is Madeline, and I'm part of the Client Relations Management team here at ACRC Global. And I work closely with fertility clinics and physicians to help coordinate care and support intended parents throughout their family building journey. Today's webinar is Understanding Fertility Testing and Your Family Building Options. So, fertility test results can often feel overwhelming, and it's not always clear what the numbers really mean or what your next steps might be. So, we hope that today's conversation will help answer some of those questions and give you a better understanding of your options. So we're so excited to have Dr. Meredith Brower and Yale from Reproductive Medical Group joining us today. Dr. Brower, Yale, hello, and thank you for being here.
Thank you, and thanks. I think we're excited to be here and answer your questions and any questions that anybody may have.
Awesome, awesome. All right, let's move along. Okay, so before we begin today's discussion, I'd also like to briefly introduce ACRC Global. So ACRC Global was founded in 2015 and is headquartered in Irvine, California. Over the past decade, we've helped more than 1,300 families around the world build their families through surrogacy, egg donation, IVF support, and other assisted reproductive technologies. Our core services do include our surrogacy programs, our egg donor matching, embryo transportation, IVF concierge services, and international family building support. And we do work closely with fertility clinics, attorneys, insurance specialists, and case management teams who help intended parents navigate, every stage of the journey. And whether someone is just beginning to explore their options or is already moving forward with the treatment, our goal is to provide guidance, resources, and support throughout the process. Next slide. Okay, so for intended parents who may eventually explore donor options, ACRC also maintains our egg donor database. We currently have more than 200 egg donor profiles available of fresh donation. Parents can also search and filter donors based on ethnicity, blood type, educational background, physical characteristics, personal interests. And each profile does include a detailed background, childhood photos, and in many cases, video introductions. And all donors do complete medical history reviews and genetic carrier screenings before becoming available for matching. And some of our intended parents, they begin IVF using their own eggs, while others eventually explore egg donation options. And we're happy to support both pathways. Okay, so now I'd like to officially introduce today's speakers. Dr. Brower, thank you again for being here with us today. And if you want to take a moment to introduce yourself, and tell everyone a little bit about your background.
My name is Dr. Meredith Brower. I'm here today with Yale, we are both part of the Reproductive Partners team. Our practice is we have multiple offices, Beverly Hills, Torrance, Irvine, and Long Beach. So we have a big team, a big group of physicians. I'm located in the Beverly Hills office. Um, I myself am a fertility specialist. I'm a long time LA native. I did all of my training here in Los Angeles at UCLA and at USC. And I've been part of the Reproductive Partners team here for a couple years. And as a practice, Reproductive Partners is one of the more sort of oldest, I want to say, established fertility clinics in Los Angeles. We've been around for over 30 years. We have a really wonderful, experienced group of physicians, and we take care in terms of like the spectrum of care. We do literally everything from preconception consultation, meaning people who just want to optimize ahead of getting pregnant, to evaluation of people who are having a hard time getting pregnant, to preserving for people who aren't ready to be pregnant, to LGBTQ family building, and then also people who are also using what you'll hear us refer to as third-party services, which is just a umbrella term to include the use of another person in the building of the family. So that would be an egg donor, a sperm donor, or a surrogate. And there's many reasons why an individual or a couple may be using those things, some of which we'll talk about today. So we kind of do the whole spectrum of care, and that's who we are here. And Yale's a wonderful part of our team who supports in making patients' journeys smooth and maybe even fun. So I'll let Yale introduce himself really quickly, and then I just want to say before we get started, I think that Madeline has a bunch of questions that we'll answer today, but I think this is pretty free form. We are here to answer your questions. That is our goal and purpose today. And so if you have logged in, please feel free to Madeline, whatever the best method is, if you want them to put them in the chat or message you directly so that you can ask them
Mhm.
however you want to get your questions to us. That's why we're here today. So please don't be shy and getting them to us.
Yeah, definitely. We do have a chat that you guys can write into at any point, and we'll address all those questions. So thank you so much for sharing that, Dr. Bauer. And yes, Yale, hello, how are you?
I'm good.
Yale.
Thanks so much for today and for including us here at RPMG, Reproductive Partners Medical Group. And as Dr. Brower mentioned, we also have a clinic in Irvine, Fertility Centers of Orange County.
Mhm.
And my role as outreach coordinator here is to really be the liaison for those intended parents starting and to be really there as a resource. I'm always happy to do a Zoom or talk over the phone or even meet for coffee near the office if you live near us at any of our four clinics. My husband and I have two daughters. We have a 4 and 6-year-old, and we were fortunate to actually work with Dr. Wong here at RPMG. So it's a full circle moment for me to be back here. And, we used an egg donor, and we were fortunate to have the same surrogate carry both of our girls. And as cheesy as it sounds, we wouldn't have a family if it weren't for this process. It's pretty amazing. Just really how embryos are created and how either surrogates or really anyone gets pregnant for that matter. We were actually in the lab today watching eggs be fertilized, and it was really fascinating. I've seen part of the process, but to actually see it in person was amazing. I got goosebumps watching. So what Dr. Brower is doing and our other doctors is fascinating. It's amazing. And, we wouldn't have families if it weren't for it. So I'll let you take it back over, Madeline. But at the end, we'll share our contact information. I have a Calendly link that I'll drop into the chat if anyone's interested in scheduling a consult.
Perfect. Yeah, thank you for sharing all that. I really appreciate it. All right, let's do it. Oh, okay. And for us as well, before we jump in, I'd like to share our consultation link as well. So whether you're exploring IVF, egg donation, surrogacy, or simply looking for guidance, we're happy to also discuss individual situations and answer any questions you have. And again, if you do have questions throughout the webinar, please feel free to write in the chat. We'll have a Q&A and we'll answer any questions. All right, let's get started on the first one. Okay, so let's start with the basics. Why is fertility testing such an important first step for someone who's beginning their fertility treatment?
Okay. Um, Fertility testing is you know, uh, this is going to help design in order to provide individualized care to any given person, you need to understand what you're starting with. Okay, so I would argue before you even test, the first most important step is understanding anybody's goals, right? So, like,
Yep.
before you even start digging into the testing, which is obviously the first step in a formal evaluation, right before
Mhm.
that, the most important first step is understanding who you are, what your journey's been so far, if there has been one at all, and what your reproductive goals are. Your whole entire big picture reproductive goals for your family, building your family. That is essential,
Right.
because that sometimes will even dictate which testing is done, right? So once you understand who this person is and what their story is and what their goals are, then you move into testing. Um, that testing is often of the basic building blocks for a pregnancy, right? And I'm talking in very general terms here, right? Because people build families in so many ways.
Right.
But again, remember our building blocks then are eggs, sperm, and a place to grow a pregnancy, the uterus. So,
Right.
again, we need to understand, and everybody's going to be different, right? Everybody's going to have a different egg number, and not all the semen analyses are going to be different. So, you need to understand then what any individual's working with in order to create a plan. And also to counsel on sort of what is it that we're working with, and what might be those expectations for treatment. And as individuals or couples are choosing between different treatments, they also need to understand what the prognosis might be. And that prognosis is going to depend on the testing that we do. Um, so I think that you need a full picture for
Right.
any individual, which will include again who they are and their story, their goals, and then these tests to assess certain aspects of their fertility to be able to come up with a plan that matches their goals. And then you try to come up with the plan that it gives them the highest likelihood to achieve whatever their reproductive goals are.
Awesome. Yeah, that's so true. You're like, okay, first things first, testing, but wait a second. Let's take a step back and what do you want? What are your goals? That is so true. And thank you for sharing that.
Yeah.
Okay, question number two. So what are the key fertility tests for women, and what does each test tell us about reproductive health?
Yeah, that's a good question. So, we had just started to talk as we talked about the testing. What are the things that we can test for? So, our most basic sort of fertility evaluation, as I mentioned, would be of eggs, sperm, the uterus, and potentially the tubes. When we test eggs, there's two parts of the eggs we're always talking about. There's one part that's testable. Egg number. There's two parts to the number of the eggs and the quality of the eggs. The number is the testable part, right? So I use this analogy all the time to sort of describe the difference between egg number and egg quality. And I'm going to get into the details just a little bit, but if you think about an ovary like a basket, and all the eggs that are in the ovary are balls inside that basket, when we assess for egg number, what we are trying to determine is how full the basket is. We do that with ultrasound. So, an ultrasound to look at the ovaries and do something called a follicle count, which is counting up the number of eggs that you might see at any given moment, as well as the hormone that's from the blood. That hormone is called AMH, or anti-Müllerian hormone. And those are the two primary ways that we're understanding egg number, or again, sort of like how full is the basket. And we don't ever get to say, oh, you have 376,000 eggs left, but we do get to say the basket is, where we expect it to be. Is it very full or very empty? And that often guides options as well as treatment protocols. The quality piece, I'm going to mention it even though I know we're talking about testing and it's not something we can test. In the
Mhm.
basket, there are green balls and red balls. And the green balls are the normal eggs that give us babies, and the red balls are the abnormal eggs that aren't going to give us babies. And no matter how young you are, there are green and red balls in the basket. So even when we use egg donors, which you guys support in doing,
Mhm.
donors have red balls in the basket, right? Now they're
Right.
25, so a very high percentage of the balls in the basket are green, right? They have a very high percentage of normal eggs,
Yeah.
but everybody will have both kinds. So, what egg quality is, again, just as a mention, it's not a testable entity, is the ratio of green balls to red balls, the ratio of good eggs to bad eggs. Again, so it gets always integrated in conversation. It's not a testable entity.
Mhm.
I think your question to me was about females in particular. Um, I may talk about males just because I'm here, but the
We can
other
definitely
the
get into
other
that.
the other, and we said we don't want anyone to feel left out. The other part of the primary testing for females is of the uterus, right? So their standard test is some sort of assessment of the uterine cavity for somebody who's using their uterine cavity. Now, if that female is not intending to carry a pregnancy because her partner is also female and her partner is going to carry, or because she's using a surrogate for any reason, or because she's just preserving, she's not ready to think about her uterus. She can
Right.
forego that. But anyone who's planning to use their own uterus in the near future needs some assessment, either with a saline ultrasound where we put water in the uterus. That's probably
Mhm.
the prime. Here at Reproductive Partners, we do those a lot. Sometimes
Yeah.
some patients will come in with something called an HSG or hysterosalpingogram, which can also assess the uterus. And at that same time, we're typically making sure that the tubes are open as well. Right. So that's that. That what I walk you through is just like the standard testing. Sometimes there's
Right.
other testing that we'll do that's kind of next, like the next layer of testing that's for everybody, what I've just described.
Yeah.
But there's other tests for instance, somebody who you're suspicious for endometriosis, right? We've been doing increasing number of tests from an organization, a company called Her Resolve, which is a newer blood test for the first time in the long history of fertility. We can actually get a strong sense of somebody's risk or whether or not they have endometriosis from blood sampling. You know,
Wow.
2 years ago or a year ago, I would have sat here and said, you have to do a big surgery or laparoscopy for that. But so
Right.
far, this test has like about an 80% sensitivity to to
Wow.
to identify endometriosis from the blood, and a very high specificity, meaning that if it turns positive, the likelihood that you actually have it is upwards on 98%. So I'm not going to say that's standard testing, but
Mhm.
again, once you learn somebody's story, you may
Right.
decide that something like that is indicated. So that's kind of like what I think about in terms of testing for females on a most basic level.
Mhm.
For the males, it's typically a semen analysis. So same thing, your standard testing is going to be a sperm number. In a semen analysis, you're looking at, how many sperm are there? Are the sperm moving? Are the sperm shaped normally? That would be your standard analysis. Now, once again, you may get some piece of the story or something in those initial results that once you may want to sort of dig a little deeper. And so you may have a physician or your provider recommend other testing of the sperm. There's something called a DFI or DNA fragmentation index, which is like looking at the sperm on a more detailed level. Our urologist, Dr. Weinberger, James, he always gives that. He talks about something about looking under the hood, or there's like an airplane. He gives some analogy where he's got an airplane and there's packages. Anyway, so he's like, it's looking a little deeper to see if the sperm have any sort of increase in the fragmentation of the DNA. So it's called a DFI or DNA fragmentation index. So again, that's kind of like the basic level of testing that almost everybody gets, and then
Yeah.
something that might be indicated based on the story or history.
Awesome. Yeah, thank you for breaking all that down. I think that you'll see a few of our next questions might go into more depth about a few of the things that you talked
Great,
about.
great.
Because many patients focus heavily on their AMH level.
Yep.
So that was part of the next question. How should AMH be interpreted?
Yeah.
And what are the common misconceptions about it?
Yeah, I mean, AMH is a measure of egg number. Okay. AMH is a hormone that's made by the follicle, which is really the same thing as the egg. It's sort of the support structure around it. But so the more you have, the higher that number will be.
Hmm.
I always think it's helpful to have more than one measure of egg number, right? So
Yeah.
often using both the follicle count and the AMH together probably gives you the best sense of what somebody's true egg number is. And in that
Mhm.
analogy we just created, right? That's like the fullness of the basket. A very common misconception around AMH is that or just a common misconception in general is that you can measure the quality of an egg,
Right.
or that having low egg numbers also means you have poor quality, or that having high egg numbers means you have good quality. And that is a really common misconception. People come into me all the time and say, "Oh yeah, I have my AMH. I've got really good quality eggs." And I think, I hope so. That's my
Right.
hope. That is my hope for you. But you don't know that for certain. And so that's the most common misconception, because there are many things that predict quality. Age
Hmm.
is not one of them. And so you can even look, so if you look at young women who have, if you look at, and there's so many studies that show this, if you look at young women who have never tried to conceive, AMH has no predictive value in their ability to conceive the old-fashioned way, spontaneously. So that means
Hmm.
you can be 30 years old and have really low egg numbers and have no problem getting pregnant at all because, again, quantity doesn't predict quality. Because you can have an empty basket full of green balls, or you can
Yeah.
have a really full basket full of red balls. And so I think that's probably the most common misconception I hear about egg number and or just AMH as a test.
Yeah, awesome. Thank you for clearing that up. It is, I feel like that is such a thing, you have a high AMH and you think all is well, all is
I
dandy, but
know. But it is
there's
good. I mean, it's not bad to
right.
have a high AMH, but we have to remember that unfortunately time plays a role. The most important predictor of egg quality is age. As we get older, green balls turn red. They
Mm,
they change
yeah.
teams. And that ratio becomes less favorable and it does some it's still good to have a good number of eggs, right?
Yeah,
But it's not predictive of the quality.
right. Awesome. Thank you for clarifying. Okay, so the next one, of course, fertility isn't just about female factors.
No.
So what fertility evaluations should men undergo? I know you touched on this.
Yeah.
And why is male fertility testing just as important as female fertility?
Yeah, I think that the testing would be sort of what we just discussed, the semen analysis as your basic test.
Yeah.
Sometimes something like a DFI is indicated. And then I'll tell you, um, you know, if those parameters are abnormal, if there is significant abnormalities in the semen analysis, that should prompt more testing, right? That should prompt
Mhm.
an evaluation with a urologist who specializes in fertility to help understand why the sperm production is abnormal. And once you understand the why, is it correctable? So I'm not gonna pretend, Dr. Again, we have this incredible luxury. I should mention we have an incredible urologist in our on our team, and so he does that for us a lot of the times. But I think he does, if it's abnormal, there's some hormone testing that gets completed. There's a physical exam that gets completed to see if they can understand why that sperm production is abnormal. And again, in
Mhm.
understanding the why, is it something that's correctable? I think there's been like we're coming out of the dark ages where with the advent of something called ICSI, where you can inject a sperm directly inside the egg. I think for a long period of time we were just like, who cares? We can do ICSI. Who cares? We'll just shove the sperm right in there and it
Yeah.
doesn't even matter who they don't why do we even test them? You know?
Yeah.
And I think there is an increasing awareness that you can inject the sperm inside the egg, but the quality of the sperm that you put in there is going to impact outcomes. And it's
Mm.
going to impact the rate of fertilization and it'll impact embryo development. So I think it's really important that the male side be taken into account in the same way. And that you're, you know, optimizing the sperm as much as you're optimizing the egg for the overall best outcome.
Awesome. Yeah. Yeah, that's a great reminder. Like it's a shared journey.
It's a
And
shared journey in every way.
and we do have a good question to go with this
Yeah.
in the chat. So for male and female couples, do you recommend that they test at the same time?
I think they should both test in a timely fashion, meaning that, you don't have to come in on the same day unless you want to. Many couples like that. They like to come in. I think that
Mm.
just emotionally helps it feel like a shared experience.
Right.
And that is nice. And I encourage that. But, people are also busy. So don't wait 3 months to find the one day when you both can come in at the time that the appointment slots are available.
Right.
So, in general, in the same window of time, everybody should be getting evaluated or assessed,
Mhm.
because you don't want to have, one partner come in and then it takes 3 months for the other partner to come in. And I think, that delays, a conversation about what's going on. It delays treatment if it's necessary, and it maybe creates some resentment too. One person's participating and the other one's not. And I think that this is can be, depending on what the journey is, a really hard thing on relationships and couples, and maybe that is something that we should be trying to minimize as well.
Yeah, yeah, definitely a little emotionally challenging. But it is awesome that you mentioned before having the urologist like at
Yes.
RMPG. I feel like that is so huge and you don't really see that a lot in clinic.
I believe, Yale, are we not the only center on the whole entire West Coast, I think, that has a urologist?
That's correct. Yeah, on the West Coast. And it's nice to go in tandem with that question that we had.
Yeah.
Couples coming together. It is hard to schedule, but the nice part about that is if the male does need to be seen, it's not like he's having to contact another office and give all of his contact
Right.
information. Because we do sometimes see that men don't follow through as often as the female partners do, just call
Yeah.
and schedule an appointment. And the goal too in that is if they needed to come on the same day, we can try to arrange that or
Mm.
around the same time frame, like Dr. Brower said. And there's also ways that they can even, do their sperm testing at home and then bring it to the office
Mhm.
and ship it to the office.
Oh, wow.
So, when it comes to that, we really try to structure best to their schedule.
Awesome.
Absolutely.
All right. Let's see what's next. Okay. So if fertility test results come back abnormal, does that automatically mean a patient will need IVF? How do you determine the most
Mm.
appropriate treatment plan?
Yeah, definitely not.
Yeah.
Um, there are there are certain things that will always require IVF.
Mhm.
Using a surrogate someday, right? That always requires IVF because you have to create the embryos to put into somebody else's uterus. Um, Abnormal sperm production, that's not fixable. So right now I'm just listing a couple of indications where you're probably gonna get, stuck doing IVF. Like if
Yeah.
there's not, you still, in order to be a candidate for some of our other treatments, which include things like inseminations, where we're putting the sperm inside the uterus, you still need some sufficient quantity of sperm for success. Ideally you still have 8 to 10 million sperm. So if we can't get to those counts after consultation with urology and fixing whatever the problem is, that's something that ultimately really would require. It's not really, this is a requirement for IVF. Blocked
Mhm.
tubes, right? The egg and the sperm, that's the highway. So if the highway is closed, that is another reason that you would certainly need IVF. So there are certain things that if you run into them in your evaluation, that would be the one direction you have to head in.
Got
In
it.
general, like not every abnormal test leads to IVF, right? The other, category of treatment that we're doing really commonly is inseminations. Now, right now we're talking about treatment, right, for conception.
Hmm.
Um, and in insemination cycles, first you kind of trick the ovary to make more than one egg, and we use some concoction of medication to do that. And we put the sperm inside the uterus. Now, you can have low egg numbers and do insemination. You can have mildly abnormal sperm numbers and do insemination. As long as there's one tube open, you can do an insemination, right? So, certainly, all abnormalities do not lead to IVF. Um, there are certain indications, as I've just mentioned, that will kind of definitely lead there. But I would say most couples, most individuals, it's a conversation. Most people, not all, but many people are candidates for both. And it's just then a conversation about the pros and the cons and understanding what's best for that individual or that couple.
Awesome. Yeah, good to know.